Okay, now we'll be in chapter 47, and that's on page 1127 in your text. So we're going to talk a little bit about what nutrition is. You've ever heard the phrase, you are what you eat? Well, nutrition is what we do with what we eat. So yes, we do have to eat food, but our body has to use it certain ways. And we have certain things that are nutrients. We have our macronutrients and we have our micronutrients. Macronutrients are needed in hundreds of grams, like proteins, fats, carbs, some minerals, and some vitamins, and then some that are needed in small amounts. Some vitamins and minerals are needed in smaller amounts, like milligrams and micrograms, and that would be your micronutrients. So some of your macronutrients, which do include some minerals and vitamins, and water is needed in larger amounts. Your carbohydrates, your sugars, starches, fiber, they are digested by enzymes and they're used by the body as the glucose or for energy. Your proteins, you have two types, your essential and non-essential, actually three types, and you have your amino acids. Now, in these, you also have complete and incomplete proteins. These are also digested by enzymes and they're stored in the body tissue. And proteins is important for healing. So carbohydrates are important for energy. Proteins are important for healing. Now, fat are your lipids, your fats, oils, and fatty acids, and these actually start with digestion in the stomach, but mostly in the small intestines, again, with enzymes. So our micronutrients, again, needed in small amounts. We have different types of vitamins that are micronutrients. Your vitamins that are water soluble are like vitamin C and your B complex vitamins. Now these foods that contain these vitamins actually need to be included in the diet daily. They're needed in small amounts, but they also catalyze the metabolic process. So that's what they're needed for. We also have fat-soluble vitamins. That's your A, D, E, and K. And these can be stored in the body. So that means with having fat-soluble vitamins that you can actually overdose on these particular vitamins. So we actually are going to do an activity when it comes to vitamins. We will do this in class. You will be divided into groups where we look into the NCLEX book, Saunders book, and get foods for our vitamins and minerals, because you need to know foods that are related to these. So in our minerals, we also have micro minerals and macro minerals. Your macro minerals are just needed in larger amounts, usually over 100 milligrams, and then micro minerals are needed in smaller amounts, like less than 100 milligrams. Calcium, phosphorus, those two together are part of your skeletal system. Then you have some electrolytes like sodium, potassium, magnesium, chloride, and sulfate. You also, in your electrolytes in this list, happen to be calcium, sodium, potassium, and magnesium. Now, macro minerals needed in smaller amounts. You need iron. Iron is something that has to bind with hemoglobin. Then it helps to carry oxygen. Zinc, manganese, iodine. Iodine is important for our thyroid health. Fluoride, copper, cobalt, chromium, and selenium are just to name a few of your micro minerals. So one thing about food is that we do use our food for energy, and each type of food has a certain number of calories per gram. So a calorie, carbohydrates has about 4 calories per gram. Then you have protein has 4 calories per gram. Fat has 9 calories per gram. It's kind of interesting, and your book mentions this as well, is that alcohol has 7 calories per gram. This is why people gain weight when they drink a lot of beer, because alcohol has about 7 calories per gram. So this is our nutritional energy. Now, one thing that we think about in healthcare is we do have to think about the weights of our clients, and we really, instead of looking at just the weight, we want to consider the body mass index, the BMI. It is considered a more reliable indicator when it comes to someone's health, instead of just their ideal body weight. The ideal body weight is that optimal weight that's recommended for optimal health. However, we also need to calculate anyone's risk factors of associated diseases like heart disease and diabetes with having an elevated BMI. So in your book on 1131, we have this box 47-2 that talks about this classification. And one way that you can remember this is if you're under 18.5, a person is considered underweight. And then 18.5 to 24.9 is considered normal. So if you can remember the 18.5 to 24.9 as being normal, if it's under the 18.5, it's underweight, and then anything over 24.9 is overweight. Of course, by the time you get to 30, you have obesity. Anybody that's over 24.9, one of the things that you would do is recommend a decreased calorie diet because you need them to try to decrease their BMI. Dr. Now had a patient one time on his show, and he told the patient that their BMI was over 100, and that's a very high BMI. Now, there is a formula in your book that tells you how to figure a BMI, but that is not something that you need to memorize. You just do need to know the BMI normal so you recognize the abnormals. So by looking at this, if you had a patient that had a BMI of 23, what would you suggest? Yes, you would suggest that they keep doing what they're doing because they have a normal BMI. All right, so we are going to do a matching. We'll do this in class, and you're going to match the BMI numbers with their meaning. Now, our nutritional factor influences, things that actually influence our nutritional status, and this is on 1132. One of the things that affects a person's nutritional status has to do with their development. Whatever stage of development that they're in, like infancy and adolescence, they actually have an increased need for nutrients. And older adults, on the other hand, have a decreased need of nutrients because they have a decreased metabolic rate. A person's gender also, they do differ from men to women because of the body composition and reproduction functions. The larger muscle mass of men does require that they have a greater calorie need and a need for increased protein. And because of menstruation, women of that age require more iron than men do prior to menopause. And if a woman is pregnant or breastfeeding, lactating, they also need increased calories and fluid intake. So when it comes to ethnicity and culture, ethnicity has a lot to do with food choices, maybe like you may have a culture of food that eats certain things, like Italians are known for their pasta, Asians are known for rice, curry is known for the Indians. So, it does play a role in food choices, your ethnicity and culture. We shouldn't call food good food or bad food. It would be a better approach to say that this is a better food choice instead of saying that's a bad food and this is a good food. There's actually one universally accepted guideline when it comes to what you should eat, even though there's many programs out there. The universally accepted guideline is that you should eat a wide variety of foods to supply the nutrients that you need and eat in moderation to maintain body weight. Of course, beliefs about food, fads, there's all kinds of beliefs about food. You've probably heard an apple a day keeps the doctor away. I mean, there are beliefs about foods, and there'll be fads where people will get on a fad diet thinking it's the next best great thing. So there are beliefs. People think that, some fad diets can actually delay the aging process. I've not seen that one yet. Personal preference. Maybe you have a taste for something that you really like, and then there's something else that you really dislike. So it's a personal preference. And interestingly, children tend to take on whatever type of food their parents eat and consume or prepare, and they end up being they often carry this with them to adulthood. So if the parents are not eating a healthy diet, the children won't either. Religious practices. So some religions do practice special diets. Your Roman Catholics avoid meat on certain days. Some Protestants actually prohibit meat, tea, coffee, or alcohol. Some Orthodox Judaism and Islams prohibit pork, and some Orthodox Jews actually have to or do observe kosher customs where the foods have to be inspected by a rabbi, and they have to be prepared according to the dietary laws. So if you have a patient that's from a culture, it's always good to ask questions. Are there any religious practices that need to be observed with their diet? Lifestyle can definitely influence someone's nutritional status. I know when I was a home health nurse, stopping at the Sonic drive-in to grab a burger and fries for lunch was like the easiest thing to do because I was already in my car. So that lifestyle impacted, what I ate. Some people have a lifestyle in which they cook everything from scratch. Other people always eat out. So, it's a lifestyle. Economics is huge. Now, economics has to do with the cost of food. And have you ever heard it costs more to eat healthy? Well, it's pretty much a true statement because fresh fruits and vegetables do cost, and you have to consume them quickly before they spoil. So you can't just stock up on things like that. It seems to be that things that are higher in fats and pre-packaged and things like that tend to cost less. So economics play a role. Your medication and therapies, some drugs, the effects on drug on the nutritional status can occur. Some medications can alter the appetite, increase or decrease. Some medications may change the taste or interfere with absorption of the nutrients. So we need to be aware of any type of nutritional effects a medication may have. Chemotherapy, radiation can actually cause nausea. It can cause mouth sores, which actually decreases a person's wanting to eat because of mouth sores and nausea. And so there are therapies that can interfere with nutrition. When it comes to health, something that may affect eating can be something like ill-fitting dentures or missing teeth, maybe a sore in their mouth. It makes chewing food difficult. Well, another thing that you have to do after you chew the food is it has to be swallowed. So a person or a patient that has difficulty swallowing, which is called dysphagia, that is someone who's at risk for malnutrition because they have dysphagia. It could be because their throat is inflamed, or they have a stricture, or in their esophagus, or maybe they've had a cerebral vascular accident, which is a stroke, and they're having difficulty swallowing because of that. there are some other health problems that can interfere with the nutritional status, like patients who are lactose intolerant. Maybe they have celiac disease where they have an allergy to gluten, and they have to be gluten-free. Alcohol consumption. A small amount of alcohol doesn't seem to really affect nutritional status, but if a person is an alcoholic or drinks a lot of alcohol, remember I said there's a lot of calories per gram. There's 7 calories per gram in alcohol. And one thing that happens is if a person drinks excessive alcohol, this contributes to nutritional deficiencies in several ways. Alcohol ends up replacing the food in their diet. It can also depress the appetite. Alcohol has a toxic effect on the intestinal mucosa, so it decreases the absorption of nutrients that a person does take in. And it increases the need for vitamin D because it's used in alcohol metabolism. So alcohol actually causes a lot of problems. It impairs the storage of nutrients, it increases the nutrient catabolism and excretion. So several studies have actually shown that there are benefits to moderate alcohol consumption, but you can't have excessive alcohol consumption. Advertising. Have you ever been watching TV and you saw a commercial for a really nice looking pizza with the melty cheese and you can see the steam coming off the top? Hopefully I didn't make you just hungry, but advertising definitely plays a role in our nutritional status. You see it, you want it, you have to go get it. And now it's so easy to get food. You can have Uber Eats and all those kind of things to have food brought right to your door. And your psychological factors. I've heard people say that when I'm stressed, I eat. I've heard people say when I'm stressed, I can't eat. So it is really personal how the psychological eating affects a person. Eating when you're stressed, eating when you're depressed or lonely. Others feel that they can't eat in the same conditions. So anorexia and weight loss actually can indicate that there's stress or depression. Anorexia nervosa and bulimia are severe psychophysiological conditions that are most frequently seen in female clients. All right, so I have this little fun thing that I do about this for the religion part and culture, and we are going to do that in class. So when it comes to my plate and my pyramid, these are some things that have been developed by our government to help us eat balanced. I mean, it used to be called the food pyramid back when I was a child in school, and now they call it my pyramid. And then about a decade or so ago, they came up with my plate, which you can see half of that is in fruit and vegetables, but it does include all the food groups, except for I don't see water on there. But remember that even though we have all of these things, we've got my plate, we've got my pyramid, we have the recommended daily allowance of different foods, the only universally accepted guideline to nutrition is to eat a balanced diet to get the nutrients that you need and eat those in the correct amounts to maintain a healthy body weight. So if you're teaching a patient about my plate, you're going to essentially have them to enjoy their food, just eat less, don't eat oversized portions. Like I said, half the plate, fruit and vegetables, do the low fat or the fat-free milk because they do need the milk products. Low sodium, that helps with blood pressure, and then drink water instead of sugary drinks, and that helps with diabetes. One of the things that we can do is that we can, as we're assessing our patients, we can do a nutritional screening. Before I go into the nutritional screening, I do want to mention that there are some nutritional variations throughout the life cycle. This starts on 1134. Like with the neonate to 1 year, they have the demand feeding. They are fed on demand, meaning that when they're hungry, they cry, so they're fed. They also regurgitate a lot or spit up during and after a feeding, and that occurs a lot during the first year. After they're about 6 months of age, they do require iron supplementation to prevent iron deficiency anemia. You'll learn more about iron deficiency anemia when you get to 170. As they get older, toddlers, their GI tract is maturing, so they can have most foods, and they can usually eat about 3 meals a day. Toddlers do require more calories than adults because they're growing. Preschoolers do eat adult foods. You have to make sure that they're getting their nutritional needs through their food because they are still growing. They need snacks between meals. Cheese, fruit, yogurt, raw vegetables are good choices to have. And sometimes your preschooler may still require help in preparing their food, like cutting it up into bite-sized pieces and things like that. Then you have your school-age children. This is where they're really going to develop their lifelong habit of what they're going to eat. So you need to be looking at their habits, including their snacks. You need to alter their meal content. Use rewards other than food. I think rewarding children with food is actually one of the contributing factors to obesity. And you should also, at this age, be promoting them to exercise because that needs to be something they need to learn to do. Now, when it comes to adolescence, remember when we talked about in chapter 16 about the topics of health promotion based on ages. And one of the things that it talks about under adolescence is these group of patients are, because of social pressure and peer pressure, that they're at risk of having anorexia nervosa, bulimia, following fad diets. So they actually need a quart of milk per day. They also need adequate meat, vegetables, fruits, breads, and cereals. And the calcium intake needs to be high during their adolescent years. So adolescents need a well-balanced diet and adequate calories. And many times, because of social pressures, they end up wanting to not eat so they can be really skinny. Your young adults are, especially your young adult females, are at risk of having iron deficiency anemias. So in order to prevent that, they need to eat things like your organ meats, livers, kidneys, fish, poultry, leafy vegetables. And you also worry about your young adults and calcium. Calcium is needed to maintain their bones and help to decrease the chance of developing osteoporosis later in their life. And not just with calcium, they have to have adequate vitamin D as well for the calcium to enter their bloodstream. So vitamin D is important. It's also vitamin D is made in the skin. So it doesn't have to be consumed by itself. 15 minutes 3 times a week in the sun is enough for your skin to make vitamin D. Middle-aged adults, they also need to continue to eat a healthy diet with the appropriate food groups. Remember, eating a wide variety of food to get the nutrients that they need, and eating the amount of food to maintain their weight. They also have to worry about limiting cholesterol and calories because middle age, the basal metabolic rate starts to decrease. Your premenopausal women will need to have sufficient calcium and vitamin D to reduce osteoporosis. And they also need things like A, C, and E because this can reduce the risk of heart disease. Your older adults. They require some of the basic nutrition as the younger adult. However, they need less calories. They have a reduced basal metabolic rate, and they also have decrease in physical activity, so they just don't need as many calories. They need more carbohydrates for fiber and bulk because they usually have constipation. Um, Sometimes they have physical changes like they lose their teeth or they have impaired sense of taste and smell, and this can affect their eating habits. And we do need to assess whether or not they can swallow. Are they having any difficulty with swallowing, dysphagia? Because that can lead to aspiration. Now that we know some of the things that can happen through the lifespan, let's talk about some nutritional screening. And we would want to do this on admission, and then as needed, we would do it again. We're going to ask questions. Nursing history, this is on 1143. So we would want to be getting a diet history, like, asking if they have problems swallowing, do they have any problems chewing, do they have dentures, are they missing teeth, or do they have loose teeth or broken teeth, mouth sores, do they have enough money to buy food, what is their food intake, is it adequate or inadequate, do they have the appropriate place to prepare their food. I've actually taken care of elderly that didn't have running water or electricity, and they were literally using candles for light during the darker hours. And they used, they would borrow someone's water hose to fill jugs to have water. So it's really sad when you see that they don't even have the ability to cook their food. Are they living alone, eating alone? What are their physical disabilities? You want to look at their medical history. You want to look at whether or not they're obese. Have they had pregnancy? Are they pregnant? Are they alcoholics? Do they have some type of injury like a severe burn that's going to require increased nutrition, other traumas? Do they have chronic illnesses like end-stage renal disease, which requires them to be on a certain diet? Liver disease, again, they have to avoid certain foods. Do they have a fluid and electrolyte imbalance? We can look at the labs for that. Do they have GI problems like anorexia, which means lack of appetite when it's just by itself? Dysphagia, problem swallowing. Do they have nausea, vomiting, diarrhea, or constipation? Do they have a neurological or cognitive impairment that's going to impair their ability to eat? Oral and GI surgery. Have they gained weight unintentionally? Have they lost weight unintentionally in the last 6 months, especially about a 10% loss? That's usually indicative of cancer. What kind of medications do they have? Are they taking antacids, which decreases the acid in the stomach that aids in digestion? Do they take antidepressants? Anti-inflammatories, do they take aspirin, which can increase their chance of GI bleed? Laxatives, do they take diuretics? So there's a lot of things that we can look at to see, does my patient have any risk factors for nutritional problems? When I do my physical assessment, I can actually look at a patient and see, do I see signs and symptoms of malnutrition? When I'm doing a nutritional assessment, I can look at their height and their weight, look at their ideal body weight. I can see what their body mass index is. I can look at their hemoglobin, their albumin. Albumin we'll talk about later. I can look at their skin and look at their hair. Is their hair brittle or broken? Are their nails cracking, which can indicate malnutrition? You can even ask your patients to do you a dietary history and writing down what they've ate for the last 24 hours. Most people can remember what they've had in the last 24 hours. So, as promised, we're going to talk about albumin. So, Albumin is a type of protein. So we have these serum proteins. Serum means that we're getting this test from the blood. We have part of our blood is liquid, and the liquid part of our blood is called plasma. But when it leaves the body, it can be called serum. So we actually do lab tests on the serum part of the blood. Albumin, the reason we check albumin to see is it low. If it is low, it means that there's been prolonged protein depletion. So what does prolonged protein depletion mean? It means malnutrition. And prolonged protein depletion means that the malnutrition has been prolonged. So I would say this would be long-standing malnutrition. Now, if a person or patient has just gotten sick and maybe say they were in a motor vehicle accident and they broke their jaw, their mouth has been wired shut, and they're going to have tube feeding. But in the meantime, for about 3 days, they were really working feverishly to get them stable. Well, if you checked a prealbumin on this particular patient, it would probably be low because there's an acute change in the nutritional status. The albumin could be normal because it's not been prolonged yet, but a prealbumin indicates acute malnutrition. Now, when it comes to transferrin, we're on 1146. Transferrin binds and carries iron from the intestines through the serum. Now, it has a shorter half-life than albumin, and transferrin will respond more quickly to a protein depletion than albumin will. So, the transferrin can be measured directly or by a total iron binding capacity, which is your TIBC, and this can indicate the amount of iron in the blood to which the transferrin is binding. So the transferrin levels are normally found with protein loss. So transferrin levels below normal are normally found with protein loss. So it will be a decreased. Transferrin will also be decreased when there's protein depletion, like a low albumin. So we'll talk a little bit about some of the diets. And I like to look at these diets, and we're on page 1151, as a med-surg nurse. Now, you're going to talk about these diets when you get to 170 again. So this is something you definitely need to learn and take with you. If you have a surgical patient, one of the things that we do to our surgical patients prior to surgery is that we have them be NPO. NPO meaning nothing by mouth. Usually we have them NPO after midnight, meaning they can't have anything after midnight, not even a drink of water. The reason that we do this is so when we take them to surgery, they're given the analgesics and the narcotic analgesic. They're giving the I lost my train of thought. When they're putting under general anesthesia, the anesthetics, they can cause nausea. So with that being a side effect, if the patient has food in their stomach and they develop nausea, they will definitely vomit. If a patient vomits while they're in surgery, then they can aspirate and have aspiration pneumonia. So this is why we hold patients NPO. Now, when they come back from surgery, we can't just start giving them food again. They have had medications put into their body that can cause nausea even after surgery. So we generally start them with ice chips first, and that one's not on my list, but it's just common sense to give them ice chips first to make sure first that they can swallow with small amounts and that they're not going to get nauseated by having a few ice chips. If they're able to tolerate that, tolerating means that they can handle it, then you can give them some clear liquid diets. On the bottom of 1151, we have some examples of foods that can be on the clear liquid, full liquid, and soft diet, and this is very important. Clear liquid diets are things like your coffee, tea, cola, carbonated beverages, bouillon, broth, clear fruit juices like apple, cranberry, and grape. If there's another fruit juice that has something in it, it has to be strained. Popsicles, Jello, sugar, honey, even hard candy would be a clear liquid. Now, the hard candy, you would have to instruct your client that they cannot chew it. They have to let it melt. So if you was taking a tray to a patient that was on a clear liquid diet, you would want to look at the food and make sure that it is actually a clear liquid, because they can't have a cup of vanilla ice cream on a clear liquid diet. The full liquid diet includes everything that's clear, plus they can have these particular foods like milk and milk drinks. You can now have that little container of ice cream or sherbet. You can have puddings, vegetable juices like V8, refined or strained cereals like your cream of rice and cream of wheat. Now they can have a little butter or margarine on that cream of wheat. They can have eggs only in a custard or a pudding. They can't have eggs otherwise. They can have smooth peanut butter and they can have yogurt. So if the patient can tolerate a full liquid diet, they can be advanced to what we call a soft diet. It's also called a low residue diet, and it includes all the foods that are on the clear and the full. And then you can start adding some lean meats, which includes your red meat, fish, poultry. It can be ground meat like on spaghetti with pasta, scrambled eggs, omelets, poached eggs. Now they can have eggs, they can have cottage cheese. Vegetables like mashed potatoes, sweet potatoes, squash, avocados, spinach, fruit that's cooked or canned fruits like bananas and grapefruit, oranges. Now, when it comes to the grapefruit and orange, your citrus, the membranes need to be removed because this is a low residue diet. They can have breads and cereals, enriched rice, barley, and pasta, all breads. They can also have some cake and bread pudding. So those different diets. Now, a low-fat diet, sometimes we include in the cardiac diet because they need to decrease their saturated fats. And sometimes we would say that we have diets for specific disease. A low-fat diet would be like cardiac, low sodium, cardiac, low carbohydrate, maybe diabetic, decreased calorie. We have renal diets where they have to limit certain foods because their kidneys no longer work. And then we have something called a diet is tolerated. What do you think a diet tolerated means? It means you give the patient what they can tolerate. So they're not really on a specific diet, but you're actually allowing them to have what they can tolerate. So you may get a patient that's coming back from surgery and it says NPO and advanced diet is tolerated. So if you have an order that says NPO, then advanced diet is tolerated, that means you give them ice chips first, then you give them some clear liquids to see if they can tolerate it. If they can have full liquids. If they can tolerate that, then they can have soft foods, diet as tolerated. So you want to advance them after surgery to minimize the chance of having nausea and vomiting. There are also something called the dysphagia diet. I think that's on my next slide. No. So let me talk a little bit about the dysphagia diet. It's on the bottom of 1151. The dysphagia diet is patients who have problems swallowing may need their food to be chopped. They may need to have their food pureed like in a blender. Their liquids may have to be thickened in order to swallow them. So that would be your dysphagia diet. Actually, nurses may be the first to detect that a person has dysphagia. You may notice when you give someone a drink of water that they cough a little bit every time they drink, or you may see a tear run down their cheek. If you've ever gotten choked, like at a movies, eating popcorn and drinking your icy, and you get to laughing, and next thing you know, you bring a piece of popcorn down into your windpipe, and it makes you cough, 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 and next thing you know, you have tears running down your face. That's because when a person is choking, even if it's a small amount, it causes tears to run down their face or come from their eyes. The National Dysphagia Diet actually has standards of food textures. This is on 1152 in the reading, where we have 4 levels of liquid foods. You have thin, like your water. Nectar-like is a little thicker. Honey-like is thicker than nectar. And then spoon-thick is almost like a pudding consistency. And then they have 4 levels of semi-solid food, which is the pureed, which looks like baby food, mechanically altered, advanced mechanically soft, and then regular and general. So these are the 4 types of liquids and the 4 types of food. Generally, a speech therapist is the swallowing specialist. Sometimes dietitians, occupational therapists, and swallowing specialists work together to determine whether or not someone has dysphagia and what they need to do about it. All right, let's talk a little bit about our vegetarian diets. I'm interested to see if I have any vegetarians in the room. I'm a meat and potatoes kind of girl. However, a vegetarian diet can be nutritionally sound as long as there's a wide variety of foods. There are some plant proteins that can be used in the place of meat. Black beans, kidney beans, lima beans, soybeans, all can be used to replace some of those proteins. Actually, it breaks it down which one has complete proteins when you do them equal, like legumes plus nuts or seeds gives you a complete protein. Grains plus legumes are complete protein. Like brown rice and black beans, that would be a complete protein. Now, one of the things that we worry about is when a person becomes a strict vegetarian. A strict vegetarian will not consume in milk and milk products. And this is where the primary large amount of calcium comes from, from our milk and milk products. So it says on the bottom of 1142 that if you have a person that has that is a strict vegetarian, we worry about the calcium deficiency. So this can be prevented by making sure that they include like soybean milk and tofu, which is soybean curd, into their diet. They have been fortified with calcium, and then your green leafy vegetables also have calcium. Another thing we worry about in vegetarians is iron, because iron comes from animal products, animal meat. So vegans should eat an iron-rich foods and supplement with food that's rich in vitamin C to increase absorption. Iron would not absorb into the bloodstream without vitamin C. So the things that are high in iron are things like your whole grains, green leafy vegetables, raisins, and of course molasses. And these are all iron-rich foods. I know when I was giving blood back in the day, I would go have my blood tested and my hemoglobin wouldn't quite be enough, or my hematocrit wouldn't quite be enough for me to donate blood. So they started saying, well, eat raisins about a week before you come, start eating raisins, and you'll be able to donate next time. They were right. Raisins are high in iron, and if you have enough iron in your body, it causes your hemoglobin cells to mature like they should, and your crits go up. So interesting there. All right, time to climb we will do in class. So how do we improve appetite? Well, improving the appetite are some things that we have to do. This is on 1152. Giving foods that are familiar to the patient, foods that a person likes. Sometimes having relatives to bring food in, as long as it's meeting their diet that has been ordered, it is okay. If they have a decreased appetite or they're suffering from anorexia, which means decreased appetite, Maybe giving them small portions throughout the day so they don't feel like overwhelmed to eat a large plate of food. Avoiding treatments before a meal. Like, say you have a person that had colon cancer and they had to have surgery to have it removed and they ended up with a colostomy. One of the worst things you can do before mealtime is to change out that colostomy bag. So avoid things like that before a meal. Keeping the area clean, keeping things away like your bedpans, urinals. Also, another thing that really improves the appetite is to have the patient actually brush their teeth before meal. This improves their ability to taste. You can also relieve any kind of symptoms the person may have before a meal, like if they're having pain or if they have a fever. Do that before a meal so they feel better by mealtime. Reduce stress. So a lack of understanding of therapy, having fear about a surgery that's coming up, these things can cause anorexia, which is a decreased appetite. So if you see that your patient has a decreased appetite, give them a chance to talk about it so that can help to decrease their fears and improve their appetite. They will have to be in PO after midnight before surgery, so you want them to eat that night. If their surgery gets postponed and they don't go till late the next day, they will be complaining by then. So we have some lifespan considerations to talk about, and these on 1138 and 1139. You'll see that they only mention 2 lifespans. They mention the children and they mention an older adult. So children, I've mentioned before that they get their eating habits from their parents or the person that's raising them. And that's why it's important for the person who's raising children to role model a healthy diet. During the preschool and early school age years, children actually learn their lifelong eating habits. So it is the parent's responsibility or the guardian's responsibility to teach this. Adolescents who are vegan and vegetarians are at risk for some of the nutritional deficiencies, so we need to remember that. Now we get to the older adults. A lot of times your older adults are taking multiple medications, so we have to think about that because some medications have interactions with food, like warfarin, which is brand name Coumadin, which is a blood thinner. Foods that are high in vitamin K, like your green leafy vegetables, interfere with this medication and causes us to have to increase the medication. And then when they stop eating the green leafy vegetables, the medication is too much and their blood gets too thin. So it's important that they eat that in moderation. They can have it. They just have to be careful with it. We don't want them to eat large amounts. Some medications increase appetite. Some medications decrease appetite. Your glucocorticosteroids will usually increase it. Some medications will give an unpleasant taste in the mouth. Some medications that patients take have to be taken whole. Some medications cannot be split or crushed. So if a patient has problems swallowing and you have a time-release medication to give the patient and they can't swallow the tablet, you're going to have to get an alternate mean to give that medication, meaning you're going to have to call the physician because you can't crush that medication. If it is enteric coated or slow release medication, it cannot be split and it cannot be crushed. And even if it's a capsule, it can't be opened because it is a time release. OxyContin is an example of a time release narcotic analgesic. What happens when you open these time release medications, something that was going to go slow goes all at one time. So this is why you can't cut open or crush those enteric coated and time release medications. Another thing that happens with your older adults is that they may have neuromuscular disorders or they may have dementia, and it can make it difficult for the older person to eat or to be fed. You have to think about safety. So if you're feeding someone, you want to think about aspiration precautions. Aspiration precautions means the head of the bed is going to be elevated if you're feeding them in the bed. You want to give them small amounts, allow them an appropriate time to swallow. If they have dementia, you can rub over the Adam's apple area. Every time I do that, it makes me want to swallow because that's what it does to the patient as well. When you rub that area, it causes the swallowing reflex. If a person is having difficulty swallowing and to prevent aspiration, we want to use the chin tuck method. The chin tuck method means that the person is leaning forward when they swallow. Chin tuck method when feeding clients with dysphagia can help them from aspirating, because even though a patient has dysphagia and you're giving them this specially prepared food, it doesn't mean they won't aspirate on it, because if you have difficulty swallowing, you have increased risk of aspiration, and you also have increased risk of nutritional deficiencies. So another thing is you want to use the prescribed consistency of the foods, whether it's a food or a liquid. So adding a thickening agent to a liquid is something that would be a correct technique. You want to focus on their food preferences, so maybe they will eat. You want to try to keep a positive attitude during mealtime, make it a social occasion, spend nice time with your patients, make it a pleasant environment. And just because you're feeding someone pureed food, you've got this glob of orange stuff, this glob of green stuff, and this glob of brown stuff. If you're not sure what it is, look around the room, especially in long-term care settings. The patients are residents who have a regular diet. Maybe they have English peas, carrots, and fried chicken. And you can tell the patient based on that what you're giving them. And say, oh, look, it's fried chicken today. And yes, it's pureed fried chicken, but it does taste like fried chicken because they use fried chicken to puree it. I think some of the nastiest looking pureed food is the English peas because it's just that green plop stuff. But you want to make sure that you can encourage them to eat. So remember, I told you there are several different ways about a healthy diet. On 1139, it also talks about the dietary guidelines for Americans about eating decreased fat, consuming less sodium, moderation of alcohol if they do drink, and having daily foods with vitamin D, calcium, potassium, and fiber, because these are usually your insufficient nutrients. Remember, though, the universal accepted guideline to eating is that you eat a wide variety of food to get the nutrients that you need, and you eat in moderation to maintain your body weight. So I will play this in class. It's a video about foodborne illnesses. I'm just going to talk here, and this is on 1150. I like this video because it brings out almost everything that's on your page. But if you look on the client teaching section, there's a section for healthy nutrition, alterations in their diet for clients overweight and for clients who are underweight. And then it talks about preventing foodborne illnesses. So you have to reinforce that patients need to wash their hands when they're handling food and dishes, and they need to wash them before they prepare. They also need to wash their hands and the dishes and utensils and cutting boards in hot and soapy water after they've been in contact with raw meat. Remember, we have salmonella. Frozen foods need to be defrosted in the refrigerator, not on the counter, like I did my whole childhood when my mother told me to take out something out of the freezer. We need to cook beef, poultry, and eggs thoroughly using a cooking thermometer. The cooking thermometer is the best way to determine that a food is appropriately cooked. Refrigerate leftovers promptly, and you should not keep them for more than 3 to 5 days. So your older patients who have a decreased sense of smell, actually teach them to date their leftovers, and after 5 days, throw them out. If they don't date them and they can't remember, there's an old saying, when in doubt, throw it out. because if you eat spoiled food, then you will have a foodborne illness. Washing and peeling raw fruits and vegetables. Don't use containers that have been dented or damaged or have open seals. Grocery stores will have dent cells. Dented cans has an increased risk of having botulism, which is a food poisoning. Foods that are hot need to be kept hot, and foods that are cold need to be kept cold. And this is another time when you can say, when in doubt, throw it out. If you've had like a family picnic and you had potato salad that's supposed to be kept cold and it's sit outside and now is air temperature, it needs to be thrown out. You can also recommend that patients get the hepatitis A vaccine. You can also instruct patients that they should seek medical attention if they've had prolonged vomiting, fever, abdominal pain, and severe diarrhea following a meal. That could indicate that they have food poisoning. Like I said, we'll play this video in class. It's short. So, some deficiencies in nutrition. Iron. There's actually a lot of different types of anemias. Iron deficiency anemia is one of those. Green leafy vegetables and animal meat is how we get iron into our body. Remember, we need vitamin C to help that with absorption. If a person is taking an iron supplement, they don't need to take that iron supplement with milk or tea because it stops absorption. It's better to take it with water or orange juice. Calcium. Calcium and vitamin D are important to be together. Also, phosphorus comes along with calcium. This is all for the strong bones and teeth. Milk and milk products, tofu, soy products for your vegetarians, green leafy vegetables for your vegetarians. Vitamin D is also important for the absorption of that. So about 15 minutes of sun 3 days a week is enough. Phosphorus comes in meats, beans, and dairy. Your vitamin C is really important in the healing process. Citrus fruits and broccoli are some examples of that. Potassium is one of those electrolytes that we'll talk about that has a lot to do with muscle function. Bananas is the main one that's known for potassium, avocados, sweet potatoes. Protein is also important in the healing process. So if a patient's having surgery, vitamin C and protein are very important. Lean meats, eggs, dairy, seeds, and nuts are all part of the protein plan. Now, vitamin A is good for eyesight. Carrots, green leafy vegetables have vitamin A. So when a person has a deficiency in these nutrients, we can encourage them what foods to eat. Now, enteral nutrition. Enteral nutrition starts on page 1154. And enteral means is an alternative feeding method. And this enteral nutrition means it goes through the GI system or the alimentary tract. EN is enteral nutrition, and there's also TEN, total enteral nutrition, and it can be administered either by a nasogastric tube or a small bore feeding tube. It can also be administered through a gastrotomy or a jejuotomy tube, your PEGs and your PEJs. So you should be talking about these in the lab, but I'm going to go over them some. It's enteral nutrition. Your enteral access devices, one is a nasogastric tube. You will learn how to put these in 170, where it goes through one of the nostrils down into through the nasopharynx and into the alimentary tract. It is NG tube is a large bore tube that's placed in the stomach, and some of them are called Levine tubes, Salin sump tubes. This can allow the delivery of food or liquids into the stomach, and it can also allow the gastric contents to be sucked out, like through suction. NG tubes are used for feeding clients who have adequate gastric emptying, means their stomach works right, and it can be used for short-term use only. So NG tubes are not used on patients that do not have a gag reflex because it can cause poor placement and aspiration. After an NG tube is placed, before it is used, the patient has to go down for a chest x-ray to check placement after insertion before it can be used. Your another enteral access device is your gastrostomy and your jejuostomy tubes. These tubes are placed surgically and they can be used for long-term nutritional support, and it's usually more than 6 to 8 weeks. I do know of patients who use these until their death. They are surgically placed by laparoscopy through the abdominal wall and into the stomach. Now the PEG tube means the percutaneous endoscopic gastrostomy tube. So these are put in during that procedure. The percutaneous endoscopic jejuostomy tube is the same type of tube, but it's in the jejunum part of the stomach. So you have to take care of the skin around the insertion site. You actually have an opening into the body. So you watch that for drainage, because if there is a gastric leak, remember, gastric digest. So if it's leaking, it's going to digest what it's on. So we have to watch for leaks. So if I have an NG tube or a gastrostomy tube, or maybe even a small bore feeding tube, which looks just like an NG tube, I have to check my tube placement every time I get ready to use it. We can, remember, first we do chest x-ray on our NGs and our small bore feeding tubes. But after chest x-ray confirming placement, this is what we do after that. We will aspirate GI secretions and test the pH. The pH of the aspirated fluid. Aspirate means that I hook a syringe to the tube and I pull back, aspirate, to see, I'm measuring how much fluid is in there. So gastric aspirate has an acidity level of a pH between 1 and 4. It could be as high as 6 if they're taking an anti-acid. And the small intestine aspirate pH is usually higher than 6. Respiratory secretions, though, tend to be more alkaline with values of 7 and higher. You can also confirm the length of the tube on the insertion mark. The person who put the tube in should have documented what number that they inserted it to. So you can check that for placement. If that number is, more of that number is exposed, and there's, like, say you had 54 documented, and then you see 59, you know that it's come out by 5 marks. So you should question the placement if that is the case. Now you have different types of enteral feedings. These are listed on page 1159. You have intermittent feedings and you have your continuous feedings. So you should get to look at this in your labs. An intermittent feeding is when you use the formula about 300 to 500 milliliters several times a day. The stomach is the preferred site for these feedings, and they usually take over 30 minutes to go in, and we use gravity, meaning that we don't use the plunger in the syringe to push it. We let it go in by gravity. We have to monitor our patients for distension and aspiration, so we're making sure that we don't overfill their stomachs. My husband, who was in the vegetative state, could not tolerate the intermittent feedings because he would get distended quickly and start vomiting. So he had to be on a continuous feeding. A continuous feeding is generally over a 24-hour period, and they are infused by a kangaroo pump. The tubing that we use for enteral feeding does not have any port sites where you can add anything. Because it is not an IV, this is a gastric feeding. So initially we don't give more than 60 milliliters an hour, and we increase it as tolerated to the ordered rate to get the nutrition that they need. So we want to assess our clients who are receiving the tube feedings, and this is on the bottom of, let's see, it's actually on page 1165. We want to check, allergies to any of the food in the feeding. We want to assess their bowel sounds, for each feeding and for continuous feedings about every 4 to 8 hours. We need to check correct placement of tube feedings. So, aspirating the amount to see how much is in there. Now, if you're doing the intermittent feeding, it's important that you aspirate and measure to see how much is in there and put it back. We don't throw it away. We put it back because we don't want to cause an electrolyte imbalance. You want to also assess for any regurgitation, complaints of feeling full, assess for dumping syndrome. That's nausea, vomiting, diarrhea, cramps, becoming pale, which is pallor, having sweating, having palpitations, an increased pulse rate, or even fainting after feeding. You can, if you suspect that they have abdominal distension, you can measure the abdominal girth at the umbilicus. That means you're going to measure all the way around. You're going to assess for a diarrhea, constipation, and gas, which is flatus. You can look at their urine to see if they're spilling sugar or acetone. Look at their hematocrit, their urine-specific gravity. Both of these can be increased when there's a result of dehydration. You can also look at their BUN and sodium levels because some of the formulas have a high protein content. And if they're not getting enough fluid intake, the kidneys may not be able to excrete the nitrogen waste adequately, causing the BUN to elevate. The sodium levels would go up also if they're dehydrated. All right, so enteral feeding goes through the GI tract. Parental nutrition goes through the vascular. So it's referred to also as total parental nutrition, TPN, or intravenous hyperalimentation. It has to have a central line. It can't be an IV in the arm. The IV infusion of dextrose, water, fat, proteins, electrolytes, vitamins, and trace elements is what we give for TPN. The solution is hypertonic, meaning that it's very concentrated in comparison to the blood concentration. The patient does not have to be a diabetic to have their blood sugar checked. This is a high concentration of glucose, so it requires blood glucose levels to be checked. When the patient's parental nutrition has been discontinued, it has to be done so slowly, because if you just instantly stop it, you will cause hyperinsulinemia and hypoglycemia, and it can take up to 48 hours to get them off of this TPN. There's another type of intravenous nutrition. This is actually one I've never used. It's peripheral parental nutrition. It is not very concentrated and it allows it to be delivered in a regular IV like in the arm or the hand. The major disadvantage is it does increase the chance of phlebitis, which is inflammation of the vein, and it can only be used for short-term nutrition. And we use it on patients that can't tolerate the central line for the TPN. But like I said, I've never even seen this one used. Okay, that is the end of nutrition.